So there are a few challenges which make posterior circulation different from anterior circulation. The first thing is that patients universally tend to do very, very poorly with medical therapy alone, including intravenous TPA. So almost 70% of patients will have poor outcome, meaning modified Rankin score of 4 or greater. And because of the randomized trials already done in the anterior circulation, there's no appetite to randomize patients in posterior circulation. Nobody wants to take a posterior circulation basilar stroke and say, we're going to put you in the aspirin arm. As far as thrombectomy techniques, I think there is no particular difference from the standpoint of aspiration versus Stent-Retriever. The problem, though, remains access. Compared to carotids, vertebrals tend to be, generally speaking, smaller than the internal carotid arteries, which means that the larger catheter systems, the larger aspiration devices tend to be ill-suited for the posterior circulation. And the balloon guide catheters that we can comfortably use in the anterior circulation really are just too big for the posterior circulation. Now, there is observational data, single-arm data, and there's a lot of that, where I think the effectiveness of being able to open the blood vessel is very good. This is a Korean study, showed 91% revascularization with almost 45% good outcomes at 3 months, and complication rates were relatively minor. Remember that mortality, even with revascularization, remains in the 15 to 20% range. And good outcome was better in younger patients, as would be expected. This is our own experience, the Buffalo experience. Again, 91% recanalization with 80% good outcome, including modified Rankin score of 0 to 2. And then you can see we use stent retrievers, all different kinds, and aspiration as well. And this is sort of our data that we shared. And again, the favorable outcome is there more often in younger patients, more often in patients who NIH is not massively high, and absence of diabetes, which is something which is a recurrent theme in most stroke studies. So factors without association of outcome, which is a little interesting, and this is where the biggest difference comes in between anterior and posterior circulation, is that there was no significant correlation between time of onset and revascularization. And this is a little unusual, but we have known about this for over 10 years, that posterior circulation typically tends to have better collateralization than anterior circulation. And even in the absence of these prospective studies, we have always considered the time point for posterior circulation to easily be 24 hours. So if somebody comes in with a basilar occlusion, I think you can expect that they will have greater tolerance for occlusion than anterior circulation. As far as techniques are concerned, the techniques are no different. You can do direct aspiration with a large bore catheter, or you can do a stent retriever with or without a balloon guide. Now, there are advantages and disadvantages of each. Aspiration is probably a shorter procedure time. The cost is a little bit lower. Stent retriever, it's familiar, it's well proven, but probably causes a little bit of trauma. Disadvantage on the aspiration side is that your access remains a significant problem. And so if you look at comparing the two techniques, aspiration versus stent retrievers, no difference in any cohort, no difference in Siddiqui score, no difference in modified Rankin score, and really I think you can consider both stent retriever and aspiration equally good approaches for treating these conditions. So, what should be your access choice? Well, there are two ways. Most neurointerventionalists are very familiar with the femoral approach. But there's a major problem with the femoral approach, which is that you have to deal with proximal vertebral tortuosity. And if there's proximal vertebral tortuosity, getting distal access with the femoral approach makes it difficult because you have a small guide in a very large aorta, and it tends to herniate. On the other hand, the radial approach really is my preferred approach, whether it's the left side or right side, which is dominant, because most of the guide is kept in place by the radial and then the brachial artery, and so you get a lot more distal purchase and support with the radial approach. But again, every time you have a patient, you have to look at the CTA to come up with the idea as to what you want to do. Femoral certainly is more familiar, and there's no restriction in terms of sizes of devices, but definitely can be a problem if there's tortuosity and the right vertebral is dominant and you have a difficult arch. Radial approach is ideal for a right-sided approach. Left side is a little cumbersome, but you can bring the left arm over the patient so you can reach across the patient, and it's not quite as cumbersome as trying to reverse your entire room setup. The only problem with the radial approach is that you are stuck with a 6 French sheath. Now, there are people who say you can put a 7 French radial, but those radial arteries don't typically tend to do very well. My personal preference is to put in a long 6 French sheath and then put the distal end of the long sheath into the proximal vertebral and then go intracranially with larger bore aspiration catheters. So here are a couple of examples to showcase. This is a 61-year-old male with diabetes who presented with acute right-sided hemiplegia, NIH stroke score 18, and was noted to have a basilar occlusion. What you see here on the perfusion scan is there is significant increased time to peak throughout the posterior circulation. But as Ansar said earlier, we do this as a matter of routine, but it is certainly much more harder to interpret compared to anterior circulation. And so this is a case, and we'll take you through it. So again, you can see we have a long balloon guide, or sorry, 6 French long sheet that we are taking up. And we have put the long sheet directly into the vertebral because this was a very large vert. You can see there's no flow arrest with it. And once we have that, we can then employ our aspiration catheter. There goes our aspiration catheter over a wire. You can see right there is the aspiration catheter climbing up all the way into the distal basilar. There's my wire, there's my J wire, and my aspiration catheter, you can see, is climbing up all the way up to the distal basilar. This is an 072 guide catheter all the way in the distal basilar. So I think this really makes a big difference. You turn the aspiration on, and then you gradually, you can see the pump is right here, the aspiration is connected, there is flow arrest, you can see there's not a whole lot of flow coming back, and then you gradually start pulling this back as you aggressively aspirate from the guide catheter as well. And now we have, as we pull it back, you can see aspiration is complete, and probably we just ingested the clot, but let's take a look. We're going to do an angiogram, looks pretty good, so okay. We didn't pull the catheter all the way out, and here's a formal angiogram, and you have TICI 3. So I think if you are able to get a large bore aspiration catheter all the way to the clot, it's a beautiful way of dealing with this problem. Here's this is the same case. So case 2, a stent retriever. Again, you can see 88-year-old. You know, we don't discriminate in the U.S. The goal really is what's the pre-morbid status. So if a patient is in a nursing home completely dependent, they come in with a stroke, we're not going to do that. But somebody comes in, 88-year-old, who lives independently at home, driving, there's no reason why we should discriminate as we might do in other societies. So again, you can see the perfusion suggests that there is severe delay, and the posterior circulation is really significantly affected. NIH stroke score is 20. And then when you look at the basilar, there's the 2 vertebrals coming up. You follow the CTA, and at the very end, your basilar starts disappearing, and there it's disappeared. And those are the 2 PCAs. So this is a classic basilar occlusion. Here we have a large bore catheter, 6 French. Again, just the way I described, we are going to put a large bore 6 French guide catheter into the proximal vertebral. This is the guide catheter, and there goes my 6 French. And once we have access, then you do the angiogram, and there is your distal occlusion, and you can actually see the end of the thrombus in that situation. In this particular case, we cannot drive our aspiration catheter up, so what do? We cross the lesion with a J-wire, with a microcatheter, and then deploy a Stent-Retriever all the way down with our aspiration catheter just more proximal. And then once we have that in place, we then would drag our Stent-Retriever all the way back, and we start aspirating as we are doing this. And as we do this, we are aspirating significant volume, and we do a run, and we still have a persistent occlusion. So this is a case where we say, okay, let's see if we can go with a larger guide catheter. So now we are going with a Neuron Max catheter. There goes. So what is the difference? The previous was a 6 French guide. This is a 6 French long sheath. What this allows is much larger aspiration catheters to go up. And once we have that in place, then we're able to go with larger bore aspiration catheter. And now we are going to actually go up and remove the microcatheter. Once the aspiration catheter is in place again, you can see the aspiration catheter tip is sitting at the basilar terminus. And once we have this in place, there you can see my guide catheter. And we'll gradually pull this back out. There you can see aspiration is being performed by a pump. And I'm gradually dragging the wire back. And let's see what the run looks like. And we have complete revascularization. So I think these are the sort of different ways of doing things. The last case I quickly want to show is sometimes the vessel which is affected is not that large. It's a 63-year-old with ataxia and dysarthria. NIH is relatively 4. This is a right superior cerebellar artery syndrome. You know, you could say just leave it alone. TPA has not helped. Got the TPA, but again, we never wait for it. But by the time the TPA is given and the patient comes up, patient's not better. So what do? Again, radial approach. There is our guide catheter, which is right there. And we continue to advance our aspiration. There is my J-wire. Where's my microcatheter? And we put a microcatheter into the SCA, and then we deliver IA TPA. And once we have that given, you can see the thrombus is still there, so we give a little bit more. And post-op, NIH 0, perfusion is completely reversed, and the patient does well. So I think there are lots of different ways of treating posterior circulation, but typically they're the same way as you do for anterior circulation. The difference is time is less important in posterior circulation compared to anterior circulation, and access is more difficult in posterior circulation compared to anterior circulation. And also the neurologic presentation of patients can be quite complicated compared to the simpler anterior circulation. Thank you very much.
I have a brief question, Dr. Adnan Siddiqui.
Yes.
When it comes to, although it may not be the part of your presentation, but when it comes to diagnosing and imaging, how do you, because the symptoms can be quite subtle and they can be quite difficult to recognize based on only symptoms. So how do you assess such patients, which patients needs further imaging, and how you take them into cath lab and for that purpose?
It's very simple. So we have a workflow system where a patient comes in, and most of our patients are not walk-in. Most of our patients in the US come through ambulance services. And the EMS service providers will evaluate these people and will say, there may be a neurologic event. And the default is if there is a neurologic disturbance, it is a stroke until proven otherwise. So it's so your default is this is an acute stroke. And what that means is ER physician meets the patient at the ambulance bay before the patient rolls into the ER. They meet at the bay, and the ER physician says, I don't know, this may be a stroke. If this may be a stroke, the patient gets triaged immediately to CAT scan and gets CT, CTA, CTP. So unless there's no neurologic issue, then they go into the emergency room. Otherwise, the imaging is done first. So there is no guesswork where you don't really need to diagnose up front. The diagnosis is default, and that's really important about workflow. Your default diagnosis is acute stroke.